Thank you for listening to my presentation. My name is Awatif Zilabidin. I am a pharmacy student at VCU School of Pharmacy, and my topic for today is about common neurological disorders in older adults. My learning objectives for today are: I will explain the pathophysiologic and clinical presentation of Parkinson's disease. I will describe the pharmacological treatment of Parkinson's disease. I will list drugs that can exacerbate motor symptoms of Parkinson's disease. I will describe the pathophysiology and clinical presentation of dementia. I will describe the pharmacologic treatment of dementia. I will explain stroke presentation, pathophysiology, and treatment. And I will also describe epilepsy and seizures pathophysiology and treatment. Parkinson's disease is the second most common neurodegenerative disease after Alzheimer. Most visible features of Parkinson's disease are slowness of movement, muscle rigidity, tremor at rest, and postural instability. There are also many debilitating non-motor symptoms, some of which may present before the motor problems, such as depression and anxiety, cognitive deficits, sleep disturbances, bladder dysfunction, GI dysfunction, loss of smell, and cardiovascular problems. Parkinson's disease, it is caused by progressive degeneration of dopamine neurons in the substantia nigra. Less projections of dopaminergic neuron into the striatum will lead to less dopamine release in the brain. And as a result of that, the patient will experience difficulty to move at will. Medications used to manage Parkinson's disease motor symptoms work by increasing dopamine, mimicking dopamine, decreasing acetylcholine, and modulating neurotransmission. Starting with the combination carbidopa-levodopa, brand name is Cenemet, and levodopa is a dopamine precursor. It is converted to dopamine in the substantia nigra. It undergoes rapid decarboxylation to dopamine in the periphery by the enzyme dopa decarboxylase. And also, it's able to cross blood-brain barrier, unlike carbidopa. Carbidopa inhibits dopa decarboxylase, prevent the conversion of levodopa to dopamine in the periphery, which reduces the levodopa-induced nausea and vomiting. It's not able to cross blood-brain barrier, as I mentioned, not efficacious if used as monotherapy. Also, we need 75 milligram a day to saturate the peripheral dopa decarboxylase. Through this pathway, there is more levodopa crossing blood-brain barrier and converted to dopamine in the brain, leading to a prolonged effect of dopamine. We have CONT inhibitors. CONT inhibitors are not used as monotherapy, but they are used in combination with carbidopa and levodopa. Example here, it's Stalevo. CONT inhibitors, they inhibit the enzyme catecho or methyltransferase. It's the enzyme that converts levodopa to 3-O-methyl-dopa. And having this pathway, having this enzyme inhibited will prevent the breakdown and the metabolism of levodopa to 3-O-methyl-dopa, which will increase the level of levodopa crossing blood-brain barrier to the brain to be converted to dopamine. As a result of that, we will have prolonged effect of dopamine. When levodopa is given alone through oral routes, only 1 to 3% crosses blood-brain barrier. But once it is given with carbidopa, 10% can cross blood-brain barrier. Carbidopa-levodopa's absorption is affected by protein intake, and that's because the transporter L-amino acid, the active transporter system that transports levodopa through the blood-brain barrier is going to be saturated. So the drug Sinemet should be taken 30 to 60 minutes prior to high protein meals. Also, Sinemet or carbidopa levodopa's absorption is affected by high fats, high calorie meals. And also, iron salt can form chelates with levodopa and carbidopa and reduce its bioavailability. So this medication should be separated from iron supplements at least 2 hours before or after. Dopamine agonists do mimic the action of dopamine. They bind to dopamine receptors in the brain. They have longer half-life than levodopa. Um, have different PK and PD profiles. Pramipixole is mainly excreted via renal tubules. So medications that can inhibit renal tubular secretion, such as verapamil and cimetidine, they can lead to the accumulation of this drug. So this should be avoided. Ropinirole is hepatically metabolized by CYP1E2. So any drugs that induce CYP1E2 or inhibit CYP1E2 will affect its bioavailability. And that includes smoking. Smoking can induce CYP1E2. Fluoroquinolone can inhibit CYP1E2. Rotigotine has lowest bioavailability. It's been approved recently. Well, not exactly, but it was approved in 2017. It's a patch, transdermal patch. And moving on to my next amine oxidase B inhibitors are selegiline, rasagiline, and safinamide. They do inhibit monoamine oxidase B, an enzyme responsible for the metabolism of dopamine into DOPAC. It's efficacious if used as monotherapy since it prevents the breakdown of dopamine. Um, these monoamino oxidase B inhibitors, they have different PK and PD profiles. We have rasagiline is hepatically metabolized by CYP1A2 and drugs that inhibit or induce CYP1A2 can affect its bioavailability. Selegiline is hepatically metabolized by CYP2B6 to active and inactive metabolites, including L-amphetamine and L-methamphetamine. And these are stimulants, and they can cause insomnia. So this should be considered, particularly in the elderly and who are experiencing insomnia. There is an orally disintegrating tablet dosage form, and this can be considered in case of an insomnia because it can decrease the amphetamine metabolite formation. Moving on, term complications such as dyskinesia and motor fluctuations are more common with carbidopa and levodopa. And non-motor complications such as drowsiness, somnolence, impulse control disorders, hallucinations, and delusions are more common with dopamine agonists. The drugs that can exacerbate motor symptoms of Parkinson's disease are antipsychotics, particularly the atypicals. Haldol is the worst offender. Metoclopramide and phenothiazine antiemetics such as prochlorperazine and promethazine. And that brings me to my next topic, which is dementia. Dementia is an umbrella term used to describe a range of symptoms associated with cognitive impairments. Alzheimer's dementia is the most common type of dementia with 50 to 75%, vascular dementia with 20 to 30%, and Lewy body dementia with 10 to 25%, and then frontotemporal dementia with 10 to 15%. 10% of Americans 65 and older have Alzheimer's dementia in 2020, and these numbers are expected to increase, particularly in elderly 85 and older. Although the cause of Alzheimer's disease is not completely understood, there are two major players that are often cited in its progression. These are plaques and tangles. These plaques and tangles can cause neural dysfunction and cognitive symptoms, which lead to neuronal overstimulation and burnouts, and leads to neuronal death and brain atrophy as a result of that. This is the plasma membrane of a neuron in the brain, and the structure in the middle, it's a structural protein called amyloid precursor protein, APP. This protein is thought to help neuron grow and repair itself after an injury. And they're also thought, as you know, they are protein, they get used, broken down, and recycled, and that is through two enzymes, the alpha secretase and the gamma secretase. And this leads to the release of part of the protein in the outside cell, and this part is soluble. But once beta secretase teams up with gamma secretase, we get a different cut, and a different part of the protein is released to the outside cell. This part of the protein, it's not soluble, and it's called amyloid beta. Amyloid beta are sticky, and they form monomers that bond together and form beta amyloid plaques. These plaques can deposit outside of the neurons and disrupts the neuron-to-neuron communication and signaling. So if brain cells can't signal and relay information, then brain function like memory can be seriously impaired. It is also thought that these plaques can start up an immune response and cause inflammation, which might damage the surrounding neurons. This buildup of plaques initiates pathways inside the neurons that leads to activation of kinase, an enzyme that phosphorylates tau. It changes once these proteins are phosphorylated, they change their shape, and also they become misfolded and dissociate from the microtubules, disrupting the intracellular communication. And once the cell cannot function properly, they often go under apoptosis, which leads to brain atrophy. Alzheimer's disease progresses through distinct stages. First thing is the memory loss, particularly the short-term memory, language problems, mood swings, personality changes, and poor judgment. As the disease progresses, the patients start to experience behavioral personality changes. They become unable to learn and recall new information. The long-term memory becomes affected. They can experience agitation, aggression, and confusion. They also might need assistance with daily living activities. And as this disease progresses further, patients might experience incontinence, gait instability, or imbalance. They become unable to perform their daily living activities, and they might need to be placed in long-term care facility. Not all dementias are Alzheimer's. There is vascular dementia, characterized by impaired judgment or impaired ability to make decisions, plan, organize versus memory loss. It can present with slow gait and poor balance. Dementia with Lewy bodies, it's similar to Alzheimer's disease, but often it's characterized by early sleep disturbances, visual hallucinations, slowness, gait imbalance without a significant memory impairment. Frontotemporal dementia marked by changes in personality and behavior, difficulty with producing or comprehending language. Memory is typically spared in the early stages, but most people with frontotemporal dementia, they develop the symptoms at a younger age. Treatment of dementia. Acetylcholinesterase inhibitors are used to treat dementia. We have donepezil, rivastigmine, and galantamine, and they all require titration. For rivastigmine and galantamine, once the patient discontinues the medication for 3 days, then they will have to restart the titration. And if it's discontinued for 6 weeks, then the full benefit is lost. So the bottom line is the patient, they have to take medication continuously for them to get the full benefits. Adverse effects of acetylcholinesterase inhibitors are insomnia, salivation, bradycardia, diarrhea, and urinary urgency. NMDA antagonists are also used to treat dementia, and memantine is approved for moderate to severe Alzheimer's disease. This medication is also titrated or require titration. It's generally well tolerated. We also have combination therapy of both memantine and donepezil. It's called Namzaric. The titration and the renal dosing still applies to the individual agents, and this is a much more affordable and just as effective as the previous medication. And that brings me to my next topic, which is stroke. There are two types of stroke. There is ischemic stroke and hemorrhagic stroke. Ischemic stroke occurs when the blood supply to parts of the brain is interrupted or reduced, preventing brain tissue from getting oxygen and nutrients. Brain cells begin to die in minutes. A stroke is a medical emergency. Early action can reduce brain damage and other complications. Ischemic stroke is an abrupt onset of focal neurological deficit that lasts at least 24 hours and is of presumed vascular origin. Stroke is the number 5 cause of death in the US. And these are the risk factors for ischemic stroke. The non-modifiable risk factors are age, so the older we get, the higher the risk of a stroke. Females are at higher risk of stroke just because they live longer. Low birth weights. Blacks and Hispanics are at higher risk of having ischemic stroke. Family history of stroke and TIA, stroke, and heart attack. And the modifiable risk factors are cigarette smoking, hypertension, diabetes, high cholesterol, low HDL levels, EFib, sickle cell disease, hormonal therapy, oral contraceptive use, obesity, physical inactivity, cardiac diseases. Ischemic stroke can be caused by atherosclerotic cerebrovascular disease, embolism, and there's also Lacunar stroke. Lacunar stroke is caused by lack of blood flow in smaller arteries that supply deep brain structures. And the most important risk factor for the development of lacunar stroke is chronic high blood pressure. High blood pressure can cause the arteries to narrow. Stroke signs and symptoms are sudden numbness or weakness in the face, arm, or legs, sudden confusion and trouble speaking, sudden trouble seeing in one or both eyes, and sudden trouble walking. And if you suspect a stroke, act fast. F for face dropping, A for arm weakness, S for speech difficulties, and time to call because time is brain. Patients who meet the following criteria are eligible to receive alteplase. Onset of symptoms less than 4 hours and a half from the drug administration. being excluded from having a hemorrhagic stroke, age 18 and older, INR less than 1.7, platelet count more than 100,000, blood glucose higher than 50 milligram per deciliters in blood, systolic blood pressure less than 185, and diastolic blood pressure less than 110. These patients, if they meet these criteria, are eligible to receive thrombolysis by alteplase. Alteplase is a serine protease that activates plasminogen to plasmin, and plasmin break down clots. 10% of the total dose is given as the bolus, and followed by the 90% given as IV over 60 minutes. And that brings me to my next topic, which is seizure. A balance between excitation and inhibition is essential for normal brain function. In seizures, there is an upregulation of excitation and a downregulation of inhibition. Seizure is a transient alteration of behavior due to the disordered, synchronous, and rhythmic firing of populations of brain neurons. An epilepsy is the chronic condition of having repetitive unprovoked seizures. The new definition of epilepsy is having at least 2 unprovoked seizures occurring more than 24 hours apart, or having 1 unprovoked seizure with the likelihood of having more seizures over the next 10 years, or being diagnosed of an epilepsy syndrome. 1 in 26 Americans have epilepsy during their lifetime. Seizures and epilepsy are common in older adults, and there is high incidence of new onset seizures in elderly. In 15 years, over 50% of all the new onset seizures will be in elderly. Recurrence rate is 90% if untreated. There are 3 major types of seizure: focal seizure, focal onset seizure, generalized onset seizure, and unknown onset seizure. Focal onset seizure began only on one side of the brain. Generalized onset seizure began on both sides of the brain and simultaneously, and they can include tonic-clonic seizure, absence seizure, or atonic seizure. An unknown onset seizure is where the onset is not known, as the name suggests. Generalized tonic-clonic seizure it has 2 phases: the tonic phase and the clonic phase. In the tonic phase, patients loses consciousness. They might fall backward on the floor. They might experience an epileptic cry. Their muscles stiffen. The person's face might look dusky or a bit blue if they're having trouble breathing or the seizure lasts too long. And in the clonic phase, the patient arms and legs, they begin to jerk rapidly and rhythmically, and after a few minutes the jerking slows and stops. The person might regain consciousness slowly, and after the clonic phase, the patients, so as I said, they regain consciousness. Their breathing goes back to normal. Their skin start to look fine, but they're usually confused and tired. Absence seizure involves sudden lapse in consciousness and staring blankly into space. The episodes last less than 15 seconds with no aura. Myoclonic seizures are non-rhythmic jerks resulting from very brief involuntary muscle twitching of the upper limbs. Atonic seizures are sudden loss of muscle tone, causing the person to collapse to the ground. And there are many factors that can precipitate seizure. Um, having cerebrovascular diseases are the most common underlying cause of seizure in elderly. But also there are other reasons, other factors such as drugs. There are certain drugs that can reduce the seizure threshold, such as theophylline, alcohol, high-dose phenothiazine, antidepressants, stimulants, meperidine, tramadol, linezolid. Tumor also can precipitate seizures. Metabolite disorders such as hypoglycemia, uremia, infections, cerebrovascular accidents, Alzheimer's disease, also sleep deprivation, emotional stress, and hormonal changes can trigger precipitate seizures. Most common type of seizures in elderly is focal seizures. They tend to be confused, disoriented. They have memory disturbances during the seizure, and after the seizure, their confusion might last hours to days. The factors in selecting an anti-epileptic drug are the type of seizure, the pharmacokinetics, the dosage form, the ability to swallow the medication, the potential for drug interactions, the dosing regimen, the side effects profile, and the cost. Most anti-epilepsy drugs normalize brain activity by reducing excitation and or enhancing inhibition or both. These are epilepsy treatment options. And for partial seizure, we have phenytoin, carbamazepine, phenobarbital, gabapentin, oxcarbazepine, pregabalin, lacosamide, tiagabine, and vigabatrin. For generalized seizure, we can use broad-spectrum anti-epileptic drugs. Benzodiazepines are the drugs of choice to stop convulsive seizure. They come in different dosage forms. If the patient is hospitalized, lorazepam IV is a drug of choice. In patients with hepatic disease, levetiracetam is preferred. In patients with moderate and severe renal failure, carbamazepine and valproic acid are preferred. Phenytoin, phosphonatoin, carbamazepine, oxcarbazepine, and lamotrigine should not be prescribed in elderly patients with cardiac conduction abnormalities or a history of ventricular arrhythmia. A few newer anti-epileptic drugs have less interactions with other drugs and hepatic enzymes and plasma proteins, and those are gabapentin, levetiracetam, and tiagabine. And this is a list of adverse drug reactions. I'm going to mention only a few of them. Carbamazepine, lamotrigine, phenytoin, phenobarbital, sulfonamide, they can cause some serious rashes. Pregabalin can cause thrombocytopenia. Vigabatrin can cause permanent vision loss. Topiramate can cause metabolic acidosis, kidney stones, acute angle glaucoma. Also, phenytoin, phenobarbital, carbamazepine, they can cause metabolic bone disease. Um, there are certain genetic markers that we can look for to avoid having those severe skin conditions, such as Stevens-Johnson syndrome and toxic epidermal necrolysis. And these markers are HLA-B1502 allele and HLA-A3101 allele. The HLA-B1502 is more common in Asian population, and HLA-A3101 allele may increase the risk for patients of European descent or Japanese origin. So for carbamazepine, oxcarbazepine, and eslicarbazepine, looking for these genetic markers can help the patients avoid having these severe skin conditions. And with that, thank you for listening, and I hope my presentation was helpful, and have a great day. Thank you.